I was scheduled for 3:30, then 4:15, then it's now almost 5 o'clock because I have to leave for a call. Professor Arif Kulim's sister has died. So basically that was my constraint. So we will just zip through the things. Medicine I learned from a person, if at all I've learned something. And he would come and say, भाई ये लड़का है, उम्र 12 साल है, नोट्स भी हैं, थोड़ी तिल्ली बड़ी हुई है, जिगर बड़ा हुआ है, तो भाई क्या हुआ? भाई ल्यूकीमिया हुआ ना. So this is what it is all about. Medicine is all about thinking, because you can have all these lists. And I was impressed by a person who was our senior star. He would give you 100 causes of hepatosplenomegaly and lymphadenopathy, and sometimes would miss a spleen or a liver. So basic thing is not missing physical signs, and then we can always come and open up the books and discuss things. But there are few things which are very, very common. Other thing that physician would always ask us, what is the most common cause of pain abdomen? And we would say duodenal ulcer, flan, flan, flan. And he would say the cause of pain epigastrium is liver. भाई liver में pathology है, pain epigastrium यहाँ है. So liver extends through the epigastrium, and we must all remember this. So can we go a bit more? I'll skip this. This is the surface anatomy, upper border and lower. Just right, next. We just go to the next. Yes. So that is what we should be deciding about liver very quickly. Edge and border, it could be sharp, it could be irregular, it could be very irregular, which is in cirrhosis and malignancy, and same is about surface. It could be very smooth, nodular, irregular, and maybe penetrating into the skin. So that is hard, irregular liver. Next, the normal span, mid-clavicle line, 15 centimeter. So we percuss heavily from above and light percussion and palpation from below, and go for it. Hepatomegaly is the enlargement of the liver beyond the normal size. So palpation is not important, it is the span. Whether it is span by clinical method or by ultrasound, we'll consider it as hepatomegaly. Next please. Now etiology, lot many, as I've said. We can always go back, and nobody can memorize all those things which can cause hepatomegaly. But having said this, there are few things which are very common. Infections, congestive, degenerative, toxic, tumors, obstruction, lymphoreticular and blood disorders, storage, congenital causes, and miscellaneous. Next please. Now infections, viral. You would get so many patients coming with pain epigastrium, having fever, pain epigastrium, or even pain epigastrium, and you do LFTs and they are abnormal, and then you think probably this is viral hepatitis. So that is where the wisdom of pain epigastrium lies. And viral hepatitis, we all know, is very, very common. So pain epigastrium could be first sign of enlargement of the liver, and we all know liver is in itself not painful. It is the capsular tension which gives rise to the pain. So hepatitis, infectious mononucleosis, CMV, EBV, bacterial, typhoid, brucella, tuberculosis, liver abscess, protozoal, malaria, amoebic abscess, actinomycosis, histoplasmosis. So we are more concerned about among the parasitic hydatid, because that can give rise to a huge hepatomegaly or splenomegaly even. Next please. Congestive causes, tricuspid valve disease, constrictive pericarditis, CCF. This is again very, very common thing. Pain epigastrium, we are busy and we do not look at the JVP, and then probably we'll be missing heart failure. So that's very, very important thing. If we find liver, at the same time we are palpating the liver, we must be having an eye on the neck to look for any jugular venous pulsations, and if they are there, we think it could be any of these: congestive failure, valvular heart disease, etc., etc. Fatty liver of diabetes. So diabetes both ways can give rise to hepatomegaly, if it is uncontrolled or if it is getting controlled. Cirrhosis, we all know now cirrhosis is less common and chronic liver disease is more common. So we get both hepatomegaly and splenomegaly, and those shrunken cirrhotic livers are no more seen. They are seen, but obviously with less incidence. Toxic causes, tetracycline, sulfonamide, phosphorus, arsenic, etc. Next. Tumor. Hepatoma, cholangioma, hemangiomas. Small hemangiomas are very common, and you also see on ultrasound. Gallstones, strictures, CVD, see ahead of the pancreas. So that can, secondaries, leukemias, lymphomas, Hodgkin's disease. Next please. Storage causes, hemochromatosis, amyloid, glycogen storage in children. Riedl's lobe, sarci, not very uncommon in this country. Multiple myeloma, hemolytic anemia, though that they would lead more to splenomegaly than to hepatomegaly, but obviously the cause is there. Now, what we do? First, we have done physical examination, found the hepatomegaly, and then go for few tests. Hemoglobin, low in malignancy, myeloproliferative, rise in WBC, in infection, leukemias, ESR, infections and malignancy. So few basic tests. They must never be ignored. So that's basically very, very important. For example, if we find hepatomegaly or splenomegaly, we do not order these tests, and we may be missing chronic lymphatic leukemia or chronic myeloid leukemia. So the basic counts always begin with A, B, and C. So Cbc Esr urine examination, these are very, very important, and they should never be missed in any patient, basically. Urea creatinine, renal failure may occur with amyloid, LFTs, clotting profile, hepatitis serology, we all know this, we will go about these things. Next please. So certain specific tests. TIBC ferritin. I have found ferritin to be very useful because you send one sample to one lab, another to another lab, and TIBC and serum iron, they are so variable, you can't really decide. So serum ferritin, it is a must. I always send serum ferritin along with all these things because that gives you the storage of iron. So that's very, very important. Serum copper, ceruloplasmin level, urinary copper for Wilson's. Antibody screening, microsomal antibodies, antimitochondrial antibodies in primary biliary cirrhosis. Bone marrow aspiration. So if we are doubtful, if we are not getting any answer on simple peripheral film and other investigations, then we should be going for bone marrow. Ultrasound, cirrhosis, secondaries, amoebic abscess, hydrated. So ultrasound is a very, very useful investigation because not only it would tell you about liver, it would tell you about spleen, it would tell you about lymphadenopathy, it would tell you about heart failure because even congestive hepatomegaly can be picked up on ultrasound. CT if needed, pancreatic lesions, cirrhosis, secondaries, liver biopsy. Obviously we can go for endoscopies, gastroscopy and colonoscopy if needed, if we think patient is having hepatomegaly because of malignancy of these tracts. Next please. Now, can we have the lights off please? So that is the span of the liver. Just see the left lobe lying onto the left side. That is why in amoebic abscess, if we suspect an amoebic abscess in the left lobe, it must be drained. Why? Because any abscess in the left lobe can go inside and get drained or into the pericardium, and patients would develop pericardic tamponade. So that is the span of the liver. It passes through the epigastrium, it goes onto the left side. So if we are palpating liver, we must be palpating the right hypochondrium, epigastrium, and onto the left side. So epigastrium palpation is very, very important. It only hardly takes half a minute to palpate for the liver. One on the right hypochondrium, one epigastrium, and one sweep of the hand which goes onto the left and onto the spleen. So that is how it should be done. Now how we measure? Mid-clavicle line at the costal margin, that is ideal. But we can measure in the mid-axillary line, anterior-axillary line, epigastrium, etc., etc. But that is obviously for researchers. Next please. Now spleen weighs less than 1 pound, 3 centimeter thick, 5 centimeter wide, 7 centimeter long. It is usually not palpable. But in a cohort of almost 2,000 patients, young people, it was found that in 3% spleen was palpable. And they were followed for 10 years and nobody had developed any malignancy. So in very thin, lean people, young people, spleen may be palpable. And obviously we'll investigate it, but if found nothing, we should be leaving it there. But otherwise, if spleen is palpable in busy clinical setting, this is definitely enlarged. Now, spleen, basically primary diseases are very, very uncommon. Primary disease of the spleen are primary carcinomas of the spleen. It is always, not always, it's mostly hematologic. If there is lymphadenopathy and spleen is there, then probably we are dealing with hematologic conditions, nothing else. Surface marking, leave it. We just, next please. We go to the next. Palpation of the spleen. Begin from here and go up. Obviously, huge spleens are not to be missed, and they would not be missed because even if we put a hand on the abdomen, we find there is something. So basically, it's the left hypochondrium which we should be looking for, and a simple tilt of the patient onto the right side, and ask him to breathe deeply and put your hand there. So that is the problem with us. We are moving our hands. Patient should be inspiring and we should be pressing the hand and maintaining it. I always say, spleen would come and meet you. Aapko salam karegi, main yahan hu. So put your hand, maintain it there, and patient should be breathing nicely, deeply. So that is for the liver and spleen. We should wait for spleen and liver to come and touch us. So we should not be moving the hand. So that is one simple clinical method thing. Now again, splenomegaly, hematologic on the top. If clinically lymph nodes are palpable, spleen is palpable, we are dealing with the hematologic conditions. Though mostly in our setting now, as liver disease has become very common, we find spleen, a bit of ascites or something, a bit of jaundice, we are thinking about chronic liver disease. But otherwise, hematologic conditions are the main cause for splenomegaly. Infections, tumors, cyst, congestive. Congestive is again important because in portal hypertension you can have congestive, in portal vein thrombosis, etc., and other conditions, splenic vein thrombosis, splenic aneurysms, etc., that would be congestive. Connective tissue disorders is again very important thing. SLE, rheumatoid, even hyperthyroidism. Very severe iron deficiency anemia can lead to splenomegaly. Miscellaneous causes. Next. Now hematologic is the most important, and just seeing hemolytic anemias, thalassemia, erythrospherocytosis, ovalocytosis, sickle cell, they can all present with splenomegaly. So if we are thinking about hemolytic anemia, if patient is mildly jaundiced, if retics are high and spleen is enlarged, then we are dealing with hemolytic anemias. Leukemias, chronic leukemias, CML and CLL. They are both diagnoses of your clinical skills. Generalized lymphadenopathy, go for the counts. If the counts are high and 90% are mature lymphocytes, that is CLL of the same size. If spleen is very big, we do the counts are very high, and there are myelocytes, promyelocytes, every sort of granulocyte seen on the peripheral film, then we are dealing with CML. So we go for marrow, obviously, to look for other things, but basically CLL and CML both are diagnoses of peripheral film, and very expert hematologists can give a look and even can differentiate between thalassemia and iron deficiency. With iron deficiency, if we are looking at the CBCs which are coming to us, if iron deficiency, there is poikilocytosis and isocytosis. So size and shape of the cells is so variable. But in thalassemia, the size is almost the same. So if iron deficiency is extensive, we are dealing with multiple size of cells. And if it is thalassemia, it is the same size. So a good hematologist, or we ourselves having a look on the slide, can tell clinically whether we are dealing with which thing. Polycythemia, macroglobulinemia, lymphomas, essential thrombocythemia, myelofibrosis. So very big spleen in our setting would be CML, myelofibrosis, tropical splenomegaly syndrome. Kala Azar we would entertain if patient is coming from Karachi, is of Bihari origin, Bangladeshi origin, or even a belt of Balochistan. So otherwise we are not considering it. But malaria as such would lead to a very tiny spleen, malarial fever coming to us, even enteric fever. But if it's very huge and big, that is tropical splenomegaly syndrome. Schistosomiasis is uncommon. Tuberculosis, we all know tuberculosis can give rise to spleen. Subacute bacterial endocarditis. So if we are having a patient who has got valvular disease, who is anemic, who is running fever, and has got palpable spleen, we should be thinking about subacute bacterial endocarditis. Next please. The tumors and cysts, I said they're very uncommon, but splenic abscesses, they're common. They're not that uncommon, especially if patient is having multiple abscesses elsewhere. So splenic abscesses, splenic mets, cysts, tumors, they would be very uncommon tumors, primary tumors of the spleen. Abscesses and mets, they're very common. Congestive liver cirrhosis, Budd-Chiari syndrome, portal and splenic vein obstruction, thrombosis, cardiac failure, especially constrictive pericarditis, that would lead to a cardiac cirrhosis and splenomegaly. Connective tissue disorders, SLE, Feltis syndrome. Feltis syndrome is rheumatoid arthritis, splenomegaly, and neutropenia, and leg ulcers. Other disorders, Gaucher's. I've got one patient with Gaucher's, but that is a retrospective diagnosis. I didn't diagnose her. She had a massive spleen, splenectomy has been done, and she has got all those tests with Gaucher cells in the marrow. Niemann-Pick, histiocytosis, amyloidosis. Next. Now, mild, moderate, and massive enlargement. Mild is if we touch the spleen. Moderate is if the spleen is palpable between the umbilicus and the costal margin. And if it crosses the umbilicus, then it is massive. And massive spleen otherwise 1,000 grams. Mild malaria, typhoid, early cirrhosis, endocarditis, moderate cirrhosis, or any other cause, obviously. Massive enlargement, CML, myelofibrosis, tropical splenomegaly syndrome, Kala Azar, and cirrhosis. So cirrhosis can have very small spleen, moderate spleen, massive spleen, all those, including biliary cirrhosis, not only portal cirrhosis. Now, diagnostic evaluation, initial test, all these tests, obviously, this is your clinical skill or anybody's clinical skill, which test to order. Once we make a diagnosis and then we go accordingly, because in this country the tests are to be paid by the patient himself. एक मेरा दोस्त साइकेट्रिस्ट है, उससे पूछा यहाँ मेहनत भी बड़ी करते हैं, लोगों को इलाज भी करते हैं, खुश नहीं रहते, मीडिया खिलाफ है, मरीज़ खिलाफ है, सब कहते हैं लुट गया खा गए. वो मुझे कहता है यू आर फाइनेंशियल ब्रीडर्स ऑफ द पेशेंट्स. मैंने कहा वो कैसे? कहता है इंग्लैंड में हम बैठे हैं, उसको कहते हैं तुम्हारे और टेस्ट करने हैं, वो बड़ा खुश हो. उसको कहते हैं तुम्हें एडमिट करना है, वो कहता है वेरी गुड, यू आर वेरी नाइस डॉक्टर. वहाँ तो टाइम ही नहीं मिलता, अपॉइंटमेंट नहीं मिलती हॉस्पिटल की. यहाँ आप उसको कहते हैं एक्सरे कर ले, एक्सरे नॉर्मल आता है, कहता है डॉक्टर साहब कराया क्यों सी, ये ठीक आड़ा सी. So they are angry with you. They are angry because any test, even like PCR for hepatitis or genotyping, quantitative PCR, 10,000 rupees. It's hell of an amount for anybody. So these tests, obviously, we should be picking those up, the few tests which can give us the clue. So that is the beauty of clinical medicine. That once we make a diagnosis, then we can select few tests which can guide us, and then we can plan things. Cbc Esr hemoglobin would be low in malignancy, myeloproliferative disorders, WBC count, infections, leukemia, ESR, infections, malignancy, WBC and platelets, hypersplenism. So just a word about hypersplenism. Spleen is enlarged in so many things, and we get so many patients who are having cirrhotic and they've got big spleens. We do their tests, WBCs are low, hemoglobin is low, platelets are low. So where are they gone? Spleen is eating them. So spleen, even if it is not palpable, may be enlarged. We all know this, because if palpable, it is 2.5 times enlarged. So even if spleen is not clinically palpable, these patients may be having hypersplenism. And obviously, for hypersplenism, if it is eating up and leading to hemolytic anemia, we have to give folic acid. So folic acid supplementation, I routinely give to my patients who have got splenomegaly and they are cirrhotic patients. So looking at the counts, if we have got dealing with penias, then if spleen is enlarged, that is hypersplenism. Polycythemia, we do the tests, blood film in spherocytosis and malaria. Urea creatinine, leptospirosis, amyloid and septicemia, they all can lead to hepatosplenomegaly and rise in urea and creatinine. Liver enzymes which will be deranged in chronic liver disease. Next please. Now few specific tests we should be ordering if we think we are dealing with those conditions. As I said, Felty syndrome, examination question, rheumatoid, splenomegaly, neutropenia, leg ulcers. So that is we do for rheumatoid factor. Paul Bunnell test in infectious mononucleosis or one-spot test. VDRL or RPR in syphilis. Iron and serum ferritin in iron deficiency anemia. Parietal cell antibodies in pernicious anemia. B12 levels, blood cultures. Next please. Stool culture. Now about टाइफाइड. मरीज़ आपके पास आता है, टाइफाइड का टेस्ट पकड़ा हुआ है, ये विडाल कराया पॉजिटिव है, मुझे तो टाइफाइड हो गया. उससे पूछें तो मैं बुखार है, कहता बुखार तो नहीं है. मरीज़ आता है, बुखार है, 2 दिन विडाल हाथ में पकड़ा हुआ है, किसने कहा था जी? फलां डॉक्टर ने कहा था. तो विडाल्स इज एन एंटीबॉडी विच विल बी कमिंग 1 week, 10 days, 2 weeks later, and it is the rising titer which is important. And Vidal's has got 40% false positivity and 40% false negativity. So Vidal's, obviously we should be considering it again and again if we are thinking about typhoid. And just mere Vidal's positivity doesn't mean patient is having typhoid fever. Urine culture, obviously we don't go for these things because mostly they turn out to be negative. But otherwise, that is the way of diagnosing typhoid. CSF culture, complement fixation, ELISA for typhus, bone marrow, myelofibrosis, polycythemia, leukemia, Gaucher's. Next please. Ultrasound would give us an idea whether there is liver enlargement, there is an abscess, hydrated cyst, and others. CT again can give rise to, add to further things, but mostly ultrasound is good enough for spleen. Next please. The spleen is lying high above with the diaphragm on the left side of the stomach. It enlarges and comes forward and goes down. Next please. Now this is a huge spleen, and we come across so many huge spleens. We all know this. Next please. Now when both are enlarged, hepatosplenomegaly, portal hypertension, infections, anemias, marrow, endocrine, acromegaly and thyroid diseases. Acromegaly would lead to enlargement of any organ. So all these, heart would be enlarged, bones are enlarged, heart, spleen, thyroid disease, SLE. Next please. Can we go on to the next lymphadenopathy? Inguinal, abdominal. One thing which I have found very useful in clinical examination is if I want to examine lymph nodes and put hand like this, it gives me no information. It should be a rotatory movement. You do it yourself and you would realize that you are not missing lymph nodes anymore. So if we are looking for, say even if in the axilla, if I find this and make a rotatory movement, I'll be finding lymph nodes. Just slipping it down would be no good. So this is one thing which I have learned with time. And if we make a rotatory movement, then we are finding lymph nodes. If not, then probably we are missing so many. So this is one thing which the message I want to put across. So now body has got almost 600 lymph nodes. submandibular, axillary, inguinal, cervical, they are accessible. And next please. Next. Now we have got two types of lymphadenopathies, generalized lymphadenopathy and localized lymphadenopathy. Obviously, clinically we can palpate accessible nodes. Very careful, if you're very careful, you can palpate abdominal nodes, para-aortic and mesenteric. Mesenteric nodes, especially as tuberculosis is very common, draw a line from the anterior iliac spine through the umbilicus onto the left. This is the line of the mesentery, and we should be palpating across it. So very thin, lean people, if we try, we find and we palpate. I do it almost every thin person if I suspect mesenteric nodes, and sometimes it comes to be fruitful and we find lymph nodes. Next please. So generalized lymphadenopathy. Next. 5 broad categories: immune responses, inflammatory, infiltration and neoplastic, infiltration of macrophages. Next please. Infectious mononucleosis, all mononucleosis syndrome, CMV virus. Just excuse me for a minute. Tuberculosis, brucellosis, salmonella, tularemia, bubonic plague, rheumatoid arthritis, generalized lymphadenopathy, Still's disease. So patient coming with joint pains, acute fever, generalized lymphadenopathy, that is juvenile rheumatoid arthritis. Serum sickness, graft versus host disease. Next. Now, this is the crux of lymphadenopathy, hematologic things. People have done so many studies, size of the nodes, age, etc., etc. If age is above 40, a supraclavicular node is involved and it is more than 1.5 centimeter, 90% of chance it being malignant or having lymphoma or leukemia. So less than 1 centimeter may not be malignant. But even then, lymphadenopathy in any area, we should be very careful, because almost 60% of lymphadenopathies are non-specific. Mild infections, even if we do biopsies, we find reactive hyperplasia. So that's very, very important which node we are going for to get a biopsy. It should be big enough, more than 1 centimeter. No FNAs. I don't like FNAs on nodes. No FNAs. If node is there, go for the kill. Get it out. That's very, very important. Acute leukemias, Hodgkin's, non-Hodgkin's, lymphosarcoma, neuroblastomas, thyroid carcinoma, lymphocytic thyroiditis, histiocytosis, chronic pseudolymphomatous lymphadenopathy. Next. Immune deficiency syndromes. We all know acute acquired immune deficiency syndrome leads to persistent generalized lymphadenopathy, PGL. So initial syndrome may be chronic granulomatous disease of childhood, hyperimmunoglobulin, Gaucher, cystinosis, Niemann-Pick, histiocytosis. Next please. Thalassemias, congenital hemolytic anemias, autoimmune hemolytic, sickle cell anemia, they all can give rise to lymphadenopathy. They're very, very uncommon. Next please. Sarcoidosis. Sarcoid, like multiple sclerosis, was thought to be very, very uncommon in this. It is still very uncommon. But I get number of patients who have got lymphadenopathy, especially mediastinal lymphadenopathy. We investigate and find them to be having sarcoid. So it may not be accessible lymph nodes, but mediastinal lymphadenopathy. And as investigations are available, if we look on the X-ray and find mediastinal bilateral lymphadenopathy, top is sarcoid, then is leukemias and lymphomas. Tuberculosis, lymphomas, tumors, they would give rise to mostly one-sided mediastinal or paratracheal lymphadenopathy. So bilateral hilar lymphadenopathy put sarcoid, leukemia, lymphoma on the top. And we should try to differentiate it. Sarcoid, generalized lymphadenopathy, UV parotid fever, etc., etc. Drugs, hydantoin, allopurinol, they can all give rise to lymphadenopathy. Kawasaki's disease, which is in children, having coronary aneurysms, etc. Now, history can give a clue. Bartonella, cat exposure, cat scratch disease, undercooked meat, toxoplasmosis, tick bite, Lyme's disease, tuberculosis exposure. So here with tuberculosis, if cervical lymphadenopathy is there, unilateral, in this country we should be ruling out tuberculosis. If it is posterior lymphadenopathy, we think about lymphomas, leukemias. If there is no scalp disease. So that is again a unilateral cervical lymphadenopathy, which is known as scrofula. It may be Mycobacterium tuberculosis, it may be Mycobacterium sucrofluorescens. Tuberculosis exposure, intravenous drug abuse, blood transfusion history, sexually transmitted diseases, especially if it is inguinal lymphadenopathy, lymphogranuloma, venereum, chancroid, syphilis, etc. Hunters and trappers, fish handlers, travel to southwestern United States, that would be coccidioidomycosis, histoplasmosis, typhus. Typhus could be even in Afghanistan. Next please. Central and West Africa, trypanosomiasis, leishmania, typhoid. Just see the travel to Mexico, Peru, Chile, Pakistan. So Pakistan is inclusive. If we are returning, somebody is returning from Pakistan, you should be thinking about typhoid. Now we examine the enlarged lymph nodes. What is an enlarged node? Usually they should not be palpable. If they are palpable, we should try to make their size. Are they single, matted, size? 1 centimeter is very significant. Any node of 1 centimeter, if it is more, that is very, very significant. Then the site. Site is very important. Neck, tuberculosis, Virchow's node, abdominal or any malignancy which is below the diaphragm, because Virchow's node drains thoracic duct. So anything coming up there from the thoracic duct would be leading to a Virchow's node. I've seen even my own residents missing Virchow's node, which is even visible. So have a look on the neck and you can find there is a big node or big clump over here. That is a Virchow's node. So a look may be very, very important. Patients tie लगाई हुई है, collar है, सब कुछ है, लेकिन I've seen just on the very first look you find a lymph node is there. Painless. Now pain and tenderness, it may be inflammation, it may be rapid rise in the size. So pain is really no criteria to judge whether this is infection or not, because in acute leukemias, if nodes are rapidly increasing in size, they become painful. Painless and firm, rubbery, malignancy, lymphomas. Check the site draining to these nodes. This is very, very important. Always look for it. Inguinal है तो leg को देख लें, यहाँ कहीं है तो कान को देख लें, periarticular nodes, यहाँ cervical है तो अंदर हम देख लें, just a close look. That's very, very important. That site the nodes are draining, we should be looking for. Linear scratches, bruising. If there is lymphadenopathy, if there is jaundice, if there is bruises, then we are dealing with a hematologic thing. So clinically, we should be quickly looking for any bruises, etc. Check for splenomegaly, hepatomegaly, and obviously we carry out full general examination which we should be doing. But obviously in busy settings we may not do. Abnormal lymph node size criteria. Epitrochlear, more than 0.5 centimeter. Inguinal, more than 1.5 centimeter. Because inguinal are very common. And if possible, never go for a biopsy from inguinal nodes, except if they are asymmetric. asymmetric inguinal lymphadenopathy, or if there is some underlying thing which gives you a suspicion that they are to be taken out. But inguinal, mostly, they do not give us a clue to the disease. Isolated lymphadenopathy in children, 1.5 to 2 centimeter. Other lymphadenopathy, as I said, greater than 1 centimeter is very, very significant. Tender to palpation does not differentiate benign from malignant. So malignancy criteria would be hard, fixed to the skin, immobile. Lymph node consistency, rock hard, Mets or otherwise malignancy. Firm rubbery lymphoma, soft nodes, inflammation or infection, and these soft may later caseate and something can come out. Small shorty nodes, viral, matted nodes. So matted, our concept is tuberculosis, obviously tuberculosis on the top, but other conditions can give rise to matted nodes. Matted is when they are coming close together and you can't really pick one node from the other. It is a bunch of grapes, like bunch of grapes, that is matted nodes. Tuberculosis, sarcoidosis, lymphogranuloma venereum. Malignant, Mets, lymphomas. So lymphomas and malignancies, they can give rise to matted nodes. Now if nodes are there and we also got splenomegaly, then we should be thinking about these conditions. Infectious mononucleosis, Hodgkin's, non-Hodgkin's, CLL, acute leukemias, and rarely with Mets. Mets to the spleen and Mets to the nodes. Otherwise, as I said, if there is splenomegaly and lymphadenopathy, we are dealing with mostly hematologic conditions. Now, the initial tests, obviously, it would depend on the location we are looking for. Axillary lymphadenopathy in females, always go for mammogram, breast examination, etc. So any lymphadenopathy axillary in females should not be left as such. We must investigate it until we find the cause. That's very, very important. Specific indications based on location and exposure and generalized lymphadenopathy. The test, obviously CBC is the most important test in all conditions which so manual differential, monospot test. If there is mononucleosis, then obviously there are other syndromes I'll discuss in a bit which lead to mononucleosis syndrome. Next please. Now second line tests, apart from few tests, specific indications and normal initial tests. Persistent generalized lymphadenopathy, tuberculin test, rapid plasma reagent, anti-nuclear antibody, hepatitis B serology. Hepatitis B can lead to generalized lymphadenopathy, especially the acute phase. HIV testing and chest X-ray. Now third line, which is biopsy. When to go for the biopsy? One, as I said, we strongly suspect there is malignancy or secondaries. Two, if the size is more than 2 centimeter. If it is vicious, if patient's age is above 40 with constituent symptoms. Persistent lymphadenopathy for more than 3 to 4 weeks. So initially, if patient is coming to us, has got generalized lymphadenopathy or any specific lymphadenopathy in the cervical region, for example, we can wait if there are no compelling indications. If it is still persistent after that time and few tests we have done and we find nothing, then we can go for it. Malignancy or serious disease is suspected. Now, lymph node biopsy of the most abnormal or largest node should be undertaken, which we think is the abnormal or is the largest. Excisional biopsy preferred over FNA or needle biopsy. So if node is there, if it is accessible, there is no point that we should not be taking this lymph node out. That's very, very important. Efficacy, highest yield site is supraclavicular nodes and lowest yield site is inguinal. Then most common findings on biopsy, Abnormal findings but non-specific findings 40%. We send a biopsy, वापस आता है reactive hyperplasia. हम सर्जन से लड़ते हैं, हम पैथोलॉजिस्ट से लड़ते हैं, ये क्या कर दिया? 40% could be non-specific. So that's very, very important, because if a node is diseased, the satellite nodes, they may show reactive changes and they may be bigger than the active node. So that is one point which we should be considering. We should not be fighting with each other, but we should be concentrating more about the cause. Mets 25%, intrinsic malignancy, lymphoma 20%, tuberculosis 10%. Now this is a brief approach to the lymph nodes. Can we skip it? Go to the next. Now, evaluation of suspected case of lymphadenopathy. Mononucleosis type syndrome, which is fatigue, malaise, fever, atypical lymphocytes. What we are thinking about. This is a very common clinical dilemma, that we find atypical lymphocytes and we are stuck up what we are dealing with. A patient was referred to me who was basically having infectious mononucleosis. He had atypical lymphocytes, he had jaundice, he had hemolysis and very low hemoglobin, and then we found he was basically having infectious mononucleosis and not viral hepatitis. So here in the initial phase, if we are having low hemoglobin, disturbed enzymes, lymphadenopathy, it may be anything, but we should be thinking about Epstein-Barr virus infection and infectious mononucleosis. Epstein-Barr virus, splenomegaly in 50% of cases, monospot, IgM, and the tests for capsular antigen. Toxoplasmosis, 80 to 90% of patients are asymptomatic, IgM for toxoplasma antibody. Toxoplasma is not that uncommon, we know it. We do fundoscopies and find patients have got toxoplasma, especially in DG Khan and those areas. Cytomegalovirus, often mild symptoms, patient may have hepatitis, and we go for IgM CMV antibody. Next please. Initial stages of HIV infection would lead to this mononucleosis syndrome. Flu-like illness, rash, we go for HIV antibody. Cat scratch disease, which is tularemia. Pharyngitis due to group-based streptococci, that can give rise to, obviously clinically there would be fever, pharyngitis, exudatives, pharyngitis and cervical lymphadenopathy. We go for throat culture and appropriate medium. Tuberculous lymphadenitis, that can give rise to mononucleosis syndrome, and we do the pertinent test. Next please. Hepatitis B, acute phase. Fever, nausea, vomiting, icterus. We do the liver functions and hepatitis B serology. Lupus erythematosus, again, we know arthritis, arthralgias, rash, typical hematologic, neurologic and dermatologic changes. Rheumatoid arthritis, sarcoidosis, hilar lymphadenopathy and skin energy, and we go for biopsy. Next please. Lymphoma, leukemia, serum sickness, Kawasaki's disease. This is very common in Japan in children. Fever, mucocutaneous stings and vasculitis, especially of the coronary arteries. Next please. Next. Now again the causes of local are the same as for generalized lymphadenopathy. Next please. What we should be thinking about. Chances of squamous cell carcinoma in older people. ENT evaluation. Nasopharyngeal carcinomas having cervical lymphadenopathy. 35% of tumors of head and neck present as metastatic tumors to the original nodes. Young patients, infectious mononucleosis, etc. Asymptomatic individuals, if unexplained for 3-4 weeks or more, we should go for a biopsy. Next please. Mediastinal and hilar. Now If it is asymptomatic, bilateral, no fever, no nothing, maybe a bit of cough, we are dealing with sarcoidosis. If patient is smoker, having any clubbing or hypertrophic pulmonary osteoarthropathy, we should be thinking about a tumor. Bilateral, we think about Hodgkin's lymphoma, leukemias, thymoma, METs. METs could be bilateral, but mostly unilateral. Next, please. Axillary lymphadenopathy, women need careful examination, mammography and examination. Unexplained, we go for biopsy. Lymphoma is always a possibility. But if primary histology reveals adenocarcinoma, primary best C is almost certain. So that's very, very important, that if we are getting a nodal axillary biopsy and if it turns out to be adenocarcinoma, more likely to be coming from breast. Next, please. Femoral, difficult to evaluate. We've already said this. Mild lymphadenopathy is very common. If asymmetric, then it should arouse suspicion. If no evidence of regional cutaneous or subcutaneous inflammation, then biopsy is indicated. Next, please. I'm sorry because I've rushed through the slides, but at this short time, this is what it was possible. And then if a few questions, I'll take a few questions if any. But obviously, what I believe, few things are clinician's dilemma. And lymphadenopathy and hepatosplenomegaly are one of those. Because few signs are very specific. You find erythema nodosum, you know it. But if you find hepatosplenomegaly, you don't know what you're dealing with. So it is only tip of the iceberg, and we have to go down and find the exact cause. And pyramid is so big because differential diagnosis is so big. And then coming with one diagnosis may be very, very difficult at times, even with investigations.